This video provides an overview of guidelines in the management of generalized anxiety disorder, or GAD, and panic disorder, or PD, focusing on their diagnosis, management, and treatment. While anxiety is a normal human emotion, it becomes clinically significant when it interferes with daily functioning. GAD and PD are among the most common mental health conditions in adults, with lifetime prevalence rates of approximately 8% for GAD and 5% for PD in the United States. Approximately 40 million adults are affected annually. Women are 2 to 3 times more likely to experience these disorders compared to men, although this gender discrepancy diminishes later in life. This prevalence highlights the need for effective clinical interventions. Generalized anxiety disorder is marked by excessive worry occurring on most days for at least 6 months, accompanied by symptoms such as restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances. Panic disorder is characterized by recurrent, unexpected panic attacks with symptoms like heart palpitations, sweating, trembling, shortness of breath, and fear of dying. Persistent concern about future attacks or maladaptive behavioral changes is also required for diagnosis. Screening is particularly important for patients presenting with somatic symptoms or pervasive worry not linked to underlying medical conditions. Validated tools like the GAD-7 and Patient Health Questionnaire for PD are recommended for assessing symptoms and aiding diagnosis. This video will present an overview of guidelines from the American Psychiatric Association, the National Institute for Health and Care Excellence, the American Academy of Child and Adolescent Psychiatry, and the American Academy of Family Physicians. The guidelines provide evidence-based recommendations for healthcare professionals, but should not serve as standard of care, as practitioners should still consider the unique needs and preferences of their individual patient. The guidelines recommend a combination of therapy and medication as the most effective treatment approach.
The diagnostic evaluation involves identifying symptom frequency, severity, and duration, along with distress and functional impairment, differentiating anxiety disorders from other medical or psychiatric conditions, and identifying psychiatric comorbidities. The pathophysiology of anxiety and panic involves multiple neurobiological and psychological components. There can be neurotransmitter dysregulation. Decreased GABA, or the gamma-aminobutyric acid activity, leads to heightened neuronal excitability, resulting in excessive anxiety. Impaired serotonin signaling is associated with mood and anxiety regulation problems. Hyperactivity in the noradrenergic system can cause physical symptoms of anxiety such as increased heart rate and tremors. Chronic stress causes dysregulation of the hypothalamic pituitary adrenal or the HPA axis, leading to elevated cortisol and anxiety maintenance. There can also be alterations in the brain structures. Hyperactivity of the amygdala contributes to threat detection and fear responses. Hypoactivity in the prefrontal cortex reduces top-down control over the amygdala. The hippocampus is involved in memory and context processing. Its dysfunction may impair the ability to assess threats accurately. Panic disorders mechanisms include neurochemical factors. Reduced serotonergic inhibition in key areas such as the periaqueductal gray may allow spontaneous panic symptoms. Overactivation in the locus coeruleus may trigger autonomic symptoms such as palpitations and hyperventilation. Decreased GABA may fail to dampen overexcited neural circuits, facilitating panic. Increased sensitivity to carbon dioxide and lactate may trigger panic via brainstem chemoreceptors. Changes in the brain circuitry can also cause panic. The rapid fight-or-flight response is initiated in the amygdala-centered fear circuit. There is heightened interoceptive awareness of bodily sensations originating in the insula. There is impaired regulation of emotional responses and error detection in the anterior cingulate prefrontal cortex.
The recommendations from the National Institute for Health and Care Excellence, updated in 2020, outline a detailed and systematic approach to managing generalized anxiety disorder and panic disorder in adults. For individuals with GAD, the guidelines emphasize adjusting interventions based on any cognitive impairments or learning disabilities. When needed, consultation with specialists is recommended. The model organizes care into 4 steps, with each step addressing increasing levels of severity. Step 1 focuses on identification, assessment, education about GAD, and active monitoring. Tools like the GAD-2 scale are mentioned for initial evaluation. Step 2 offers low-intensity psychological interventions such as non-facilitated self-help, guided self-help, and psychoeducational groups. Each is tailored to the individual with instructions and structured materials based on CBT principles. Step 3 provides high-intensity psychological interventions like CBT or applied relaxation, or pharmacological treatments such as SSRIs. A preference-based approach allows individuals to choose between these treatments, considering benefits and risks. Step 4 addresses complex treatment-resistant cases with severe functional impairment, offering specialized interventions that may involve multi-agency teams or inpatient care. For pharmacological interventions, SSRIs are recommended as first-line treatment, starting with sertraline due to cost-effectiveness, though informed consent is needed due to off-label use. Alternative medications like SNRIs or pregabalin may be considered if SSRIs are ineffective or not tolerated. Benzodiazepines and antipsychotics are generally discouraged for routine treatment but may be used in specific short-term circumstances. For panic disorder, the guidelines provide a stepped care approach. Step 1 focuses on recognition and diagnosis, emphasizing high standards of consultation skills. Step 2 is treatment in primary care, including tailored psychological or pharmacological interventions. Step 3, review and consideration of alternative treatments if symptoms persist. Steps 4 and 5, referral to and care within specialist mental health services for complex or treatment-resistant cases. The guidelines address comorbidities, substance misuse, and patient preferences to ensure personalized care. Monitoring and reviewing medication side effects, efficacy, and adherence are critical for long-term management. Psychoeducational and therapeutic interventions should be delivered in the preferred language of the patient where possible.
From the AAFP, treatment approaches consist of pharmacotherapy, psychotherapy, and complementary therapies. For first-line medications, SSRIs and SNRIs are recommended for both GAD and PD due to their efficacy and tolerability. Benzodiazepines may be used for short-term relief but are not recommended for long-term use due to risks of dependence and withdrawal. Antidepressants should be continued for at least 6 to 12 months after achieving treatment response to reduce relapse rates. Cognitive behavioral therapy, or CBT, is highlighted as the most effective form of psychotherapy for both disorders. Techniques like interoceptive exposure for PD and cognitive restructuring for GAD are particularly beneficial. Exercise, yoga, and mindfulness meditation are helpful for reducing anxiety symptoms, though evidence is limited compared to first-line treatments. Prevention strategies include educational programs and exercise, though their effectiveness is limited.
The pharmacological interventions for panic disorder are diverse and aim to manage symptoms effectively based on individual needs. Here are some key points expanded from the guidelines. Selective serotonin reuptake. Inhibitors, or SSRIs, are often considered the first-line pharmacological treatment for panic disorder due to their efficacy and relatively mild side effect profile. Common SSRIs include fluoxetine, sertraline, and paroxetine. They are typically preferred for long-term treatment to reduce the frequency of panic attacks and prevent relapse. Serotonin norepinephrine reuptake. Inhibitors, or SNRIs, like venlafaxine, are sometimes used when SSRIs are not effective or suitable. These work by increasing levels of both serotonin and norepinephrine in the brain, helping to stabilize mood and anxiety. Tricyclic antidepressants, or TCAs, although older, can be effective for panic disorder. They are generally used as second-line options due to their higher potential for side effects, such as weight gain and sedation. Benzodiazepines. Medications such as alprazolam and clonazepam are effective for rapidly reducing panic attacks. However, due to their potential for dependence and withdrawal symptoms, they are generally prescribed for short-term use or as a secondary treatment. Other antidepressants such as mirtazapine and bupropion may be considered based on patient-specific factors such as co-occurring depression or the presence of side effects from other medications. In some cases, medications such as beta blockers, such as propranolol or atypical antipsychotics, might be used to address specific symptoms. Though these are not standard treatments, they are considered on a case-by-case basis. The guidelines emphasize that medication choices should be tailored to the individual's symptoms, history of treatment responses, side effect profiles, and any co-occurring conditions. Regular monitoring and adjustments are essential to ensure optimal treatment outcomes.
Anxiety disorders are some of the most common psychiatric conditions among the youth, with a lifetime prevalence in the U.S. reaching approximately 20 to 30%. Disorders include generalized anxiety, social anxiety, separation anxiety, specific phobia, panic disorder, and agoraphobia. The median age of onset is around 11 years, but specific disorders tend to appear at different developmental stages, such as separation anxiety during early childhood and generalized anxiety in adolescence.
The diagnostic evaluation involves identifying symptom frequency, severity, and duration, along with distress and functional impairment. Instruments like the Pediatric Symptom Checklist or DSM-5-based measures help systematically identify anxiety concerns. Anxiety often co-occurs with disorders like depression, ADHD, or obsessive-compulsive disorder, necessitating a comprehensive diagnostic approach. Proven as one of the most effective treatments, CBT focuses on helping children and adolescents develop coping strategies to manage anxiety-provoking thoughts and behaviors. Parenting factors such as overprotection or high criticism can influence anxiety. Involving the family can enhance treatment outcomes.
Medications like fluoxetine and sertraline are supported by research as safe and effective for youth. Venlafaxine, although less studied than SSRIs, shows promise as an additional option. Monitoring for side effects and rare but potential suicide risks associated with SSRIs and SNRIs is a critical aspect of care. A black box warning is present in labels of the medications. There is an ongoing shortage of child-trained mental health specialists, creating an urgent need for more accessible and cost-effective treatment delivery methods. Anxiety disorders in youth, if untreated, can lead to significant impairments in social, educational, and mental health outcomes.
In conclusion, clinical practice guidelines emphasize a multifaceted and personalized approach to assessment and treatment, integrating empirical evidence and expert consensus.
For more educational videos and opportunities to earn continuing education credits, visit us at www.advancedpractice.io.